Hello everyone, my name is Dr. Arturo Taca. I'm a psychiatrist and I subspecialize in the field of addiction medicine. And on behalf of the Elm Freedom Tree Network, I'm here it's a pleasure for me to be here to give you a talk on updates on addiction medicine. I've prepared a slideshow for you and hopefully you'll get something out of it and enjoy the presentation. Now, this is going to be our agenda. The first thing we're going to do is define what addiction is. And later on, we're going to talk about the comorbid psychiatric conditions that are associated with addictive disorders. And then later on, we're going to talk about the neural networks of the brain and what components of the brain are involved in reward. And then finally, we're going to talk about evidence-based treatments, specifically for opioid, alcohol, nicotine, and stimulant use disorders. And as we talk about the treatments of it, we're going to talk a little bit about the new treatments, the use of genetic testing, and some of the new things that are out there, including certain devices that are used and are FDA approved or FDA cleared in the use of certain conditions, and certain devices that are very helpful in things like depression, OCD, smoking cessation. To quote Bill Wilson, the founder of AA, the paths to recovery are many. Now, before getting into the lecture, we have to really understand what addiction is. Historically, we thought that addiction was a lack of willpower or a lack of more principles. But actually, addiction is a very complex disease of the brain that results in chronic changes after being exposed to a certain chemical for a long period of time. There are certain parts of the brain that we have identified that are involved in the pathways of reward, mainly the nucleus accumbens and something called the VTA, the ventral tegmental area. And these parts of the brain involve a chemical called dopamine. And dopamine in those areas are involved in reward. And so these deep structures of the brain sends these messages to the big part of the brain called the cortex. And it tells the cortex, hey, if you like that, I know where to get it. So that's kind of the cartoonish explanation of what addiction is and what parts of the brain are involved. So what is the definition of addiction? So addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and the individual's life experience. So what that's called is the biopsychosocial, and you can add spiritual into that. Okay, it's that type of model. People with addiction use or substance use disorders engage in behaviors that become compulsive and often continue despite harmful consequences. So basically, the brain is hunting for reward, knowing that it's probably not good for you, it might end in injury or death. The brain has this intestinal desire to hunt for reward. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic medical conditions. So again, what is an addiction? It's a chronic disease. It involves compulsive or impulsive behaviors. Despite harmful consequences, the brain is still looking for that pleasure or reward. And brain changes can be persistent if it's not stopped. Addiction is highly genetic. We know that because if you can imagine, if alcoholism, it can run in families. And as we talked about before, it involves several brain circuitries. But at the end, it involves several synergistic factors, not only the brain. Now let's talk about the brain a little bit. This is a picture of the brain, and on the left illustrates the big brain, the cortex. And the cortex is involved in decision-making, thinking, reasoning, and planning. And then on the right side describes the limbic system. And that is the deep part of the brain and is involved in basic drives and urges, rewards, and pleasure. I like to call the cortex the wizard brain, the all-knowing part of the brain that is the executive of the company, right? And the limbic system I like to refer to as the lizard brain, something that's just only interested in pleasure. So the lizard brain and the wizard brain actually work together, and they take all the senses it captures from the eyes, from the ears, from the nose, their environment, and it makes sense of the environment, makes a decision together. Now in addiction, the lizard brain's in control. So what we have to do, one approach to controlling these urges is reduce the activity of the lizard brain so the wizard brain can make those decisions. So what happens to the brain? This is a illustration of the brain. On the left side, there's the blood flow represented in this green, yellow, and red colors of a healthy, normal person. And you see what happens when people are using meth in the middle, but after months of abstinence, you can see persistent changes in the brain of a meth user. So you see the blood flow kind of returns back to normal. However, if you look at the black spots in the brain, those are kind of brain tissue that's kind of disappeared. So you've heard that the brain of a meth user turns into Swiss cheese. Well, this is what it really looks like. So can addiction be cured? Like other chronic medical conditions, there are no cure. Things like high blood pressure, diabetes, asthma, okay? They have no cure. But just like those other chronic medical conditions, addiction can be treated and successfully managed, which means you can prevent an early death. So combining treatment with medications and behavioral therapy is the standard, and treatment should be tailored. Not everybody has the same experience. Some people may suffer from a depression. Some people may suffer from PTSD, and those things have to be identified and correctly treated. So if you look at the slide, the comparison of relapse rates between substance use disorders and other chronic medical illnesses are pretty similar. Substance use disorders, there's a 40-60% relapse rate compared to high blood pressure, hypertension, and asthma. So I'm from St. Louis, and one thing that St. Louis is very famous for is the iconic Anheuser-Busch dynasty. The industry was born there, and Busch beer, Budweiser beer, was born in St. Louis. So essentially, that beer built St. Louis. Everything revolves around Anheuser-Busch. And so you might see this, a typical advertisement for alcohol, which would suggest that if you drink our product, look at all the sexy women that you might run into. Or if you were a woman, look what drinking Budweiser beer may make you. That's the sexy side of alcohol. What they don't show you, or what they don't tell you, is the not so sexy side of alcohol, which is the medical consequences of chronic liver disease. And this is somebody who has a condition, probably advanced liver failure, and that globular condition is what we call ascites, or accumulation of fluids that is a result of a failing liver. There's also misconceptions of alcoholism. A lot of people, when they think about alcoholism, there's a lot of homelessness. But actually, people who struggle from alcoholism look like you and me. Only 5% of alcoholics are homeless. As a matter of fact, there are even presidents that have struggled with alcohol use disorder. And this is an actual arrest record from one of our great presidents, George W. Bush, and this was his college days, and he was arrested for driving under the influence. So if you're going to treat alcoholism, you better know your medicine, because the consequences can affect most systems in the body. 90% of liver disease can be explained by chronic heavy alcohol use. 72% of pancreatitis is as a result of alcohol use. 41% of seizure disorder can be explained by heavy alcohol use. I don't think I can think of a system that's not affected by heavy alcohol use. One approach that a lot of addictionologists and a lot of doctors forget or fail to address when they're treating somebody with substance use disorders is the comorbid diagnosis, which means what's going on, what's driving them to drink, okay? It doesn't live in a bubble. There's a lot of conditions that can influence the brain to go and search for relief or pleasure. And we call those comorbid substance use or dual diagnosis. It's a common problem in psychiatric patients, and it contributes to treatment refractoriness, non-compliance, and increased health services utilizations and cost. So this next slide illustrates the variety of psychiatric conditions that are associated with risk for developing addiction. And as you can see, moving from the bottom to the top, you see things that are very common in the population: panic disorder, generalized anxiety disorder, major depression. Now, if you go up higher, which means that these have a higher risk for developing addictions, you see intermittent explosive disorder, ADHD, bipolar disorder, any disruptive behavior disorder, oppositional defiant disorder. So you see these things that you have to really search for and appropriately treat. If you don't treat these conditions appropriately, then the medications that are designed to reduce the pleasure or reward may not work as well. And we're going to talk about those medications in a second. Now, here we go. So these are evidence-based treatments for substance use disorders. They include medications, devices, behavioral interventions, and digital therapies. So we're going to cover some of these medications first for opiate use disorder. So right now, there are 3 FDA-approved medications that are used in opiate use disorder. Unfortunately, all 3 are underutilized, which means if you went to a specialized treatment facility, about half of those programs will offer any 1 or 3, okay? So only 50% of these programs will actually recommend the use of these medications. And out of those programs, only a third will actually a third of those patients will actually receive those meds. So unfortunately, even though that they are readily available, they're covered by insurance companies, they're all underutilized. We're going to talk about how some of these medications work in the brain. So the first medication is called methadone. You get this type of medication through specialized clinics, methadone clinics. And the way methadone works is that it replaces the opioid that you are getting illicitly. So this is what they call agonist therapy, which means they are stimulating that opiate receptor at 100%, okay? There are some advantages of taking methadone. One advantage is it's tried and tested for many decades. It's shown to be safe and effective. There are some issues with it. Number one, it is something that you develop a dependence to. So it's something that you have to take every day. Another challenge is that you have to show up to the specialized methadone clinic every day. And sometimes that could be a barrier to many patients. And that's called agonist therapy. More recently, the development of newer drugs took people away from that challenging situation and was designed to have these people get better access to medications and could receive these medications in the privacy of their doctor's office. These group of medications are called partial agonist therapy, and the most widely used partial agonist therapy for opiate use disorder is buprenorphine. Buprenorphine is something that you can get at the privacy of your doctor's office. You don't have to go every day, and has been around for about a decade now and has been proven to be safe and effective as well. The advantage of using buprenorphine over methadone chemically is because of its unique mechanism of action. It is a partial agonist, which means it partially stimulates the opiate receptor, but also completely blocks it, okay? There are some issues with this as well. It's a scheduled drug, just like methadone, so it does have some federal restrictions, but it is more readily available and has been developed in a few different forms. A pill, a sublingual film, and there's a few new products that are injections that are long-acting, 2 weeks to a month. Now, the last group of medications that are indicated for opiate use disorder are the antagonist molecules. Now, this means that it completely blocks the opiate receptor. There are a few advantages of this approach. Number one, because it doesn't stimulate it and it blocks it, it doesn't produce a dependence on it, so which means you don't get addicted to it. So if you stop this medication, you won't go through a withdrawal. There are some issues with it, however, because it does require complete detoxification of the opiate, and that is sometimes challenging to many patients and many doctors. The detoxification process may take up to a week, and it might be a little bit more difficult to get somebody completely opiate free. But the advantage is that this medicine comes in a pill and also a once-a-month injection. So once the person is completely detoxified from opioids, this may be an attractive option for people who want to be completely opiate free. One caveat to that is if you're completely detox, you gotta make sure that you offer any one of these three medications, because if you leave the detox brain alone, you shouldn't celebrate that. You're only halfway there, because that brain is highly sensitive to a re-exposure to opioids. You may have heard many stories where somebody has been out of the rehab doing well for a couple weeks, and then they were found overdosed and in an apartment or in a hotel. It's basically when they retox or re-expose their brain, the amount of opioids needed to get that euphoria is lower, and they're not used to it anymore. So the tolerance is low, they accidentally overdose. So once you are committed to completely detoxifying your patient, you have to have that discussion. Okay, what next? We have three choices, okay? So moving forward, we're going to talk about evidence-based treatments for alcohol use disorder. Now, there are 3 FDA-approved medications for this condition. Number one, we already talked, the number one medicine we're going to talk about is naltrexone, that same medication that we were talking about in opiate use disorder. Now, you might think, You might to yourself, well, it's an opiate blocker. Why is it effective in alcohol? Well, it works, but in a different way. It doesn't block the effects of alcohol. As a matter of fact, it goes through a different pathway. What happens in this condition, that's okay. What happens in this condition is naltrexone will still block that opiate receptor. Now, obviously, there's no opiates when you drink, but when you drink, there is a endorphin release. So you might think of alcohol stimulating a few neighborhoods in the brain, the alcohol receptors and also the opiate receptor, because of that endorphin, that secondary release of an endorphin. And that endorphin is the one that stimulates that opiate receptor. What happens when you stimulate that opiate receptor? There's a downstream stimulation of dopamine. And like we talked about before, the lizard brain likes dopamine. So when you use naltrexone in alcohol use disorder, you're kind of interfering with the reward or pleasure that you get as a result from drinking. Now, when you drink on naltrexone, you can still feel the alcohol. You can get very, very intoxicated. However, the secondary reward, the euphoria, is lessened. And if you combine that with good psychotherapy, then you have a good chance for reducing or even over time eliminating the use of alcohol. The second medication is called acamprosate or Campril, and that interferes with a chemical in the brain called glutamate and GABA. So, sorry.
It's okay.
So the second medication we use in alcohol use disorder is acamprosate or Campril, and it interferes with the GABA glutamate balance in the brain. So when you're drinking, there is an imbalance of those chemicals. And it's that imbalance that makes people kind of want to use or sometimes go through withdrawal and search for more alcohol. This will interfere with that imbalance and make it balanced again. And this is a good choice for people who have liver disease because it does not get metabolized through the liver, it gets metabolized through the kidneys. And lastly, the third medication is called disulfiram or Antabuse. You've probably heard about this medication is the one that makes you sick. So it interferes with the breakdown of alcohol and leaves it in a kind of a metabolite that is not too friendly to the brain, makes you nauseous, makes you flush, and makes you really, really sick. So this is a slide of the FDA-approved medications for treating alcohol use disorder. The acamprosate, you take it 3 times a day. Disulfiram, that's the doses for disulfiram. You have oral naltrexone once daily, and the extended release form of naltrexone called Vivitrol. And again, even though you're treating alcohol use disorder, the same rules apply when you use naltrexone. You can't have any levels of opioids in the system because it blocks the opioids and it might throw you into precipitated withdrawal. Moving onward to treatments for nicotine. Now, people don't realize that nicotine is probably it is the #1 preventable cause of death in the United States. For example, we're in the middle of an opiate crisis, and it's killing nearly 100,000 people a year. Now, alcohol is killing nearly 200,000 people a year. Nicotine and tobacco use disorder is killing 500,000 people each year. Now, it's been around forever. It's accepted just like alcohol, but it doesn't receive a lot of the attention it really deserves because it's big business. So if nicotine was a medicine, it would be a banned medicine because it does nothing except eventually will kill you. So the three choices for nicotine use disorder is nicotine replacement, a medication called bupropion. Some people might recognize that as an antidepressant called Wellbutrin, and varenicline. Varenicline is the generic for Chantix. Okay, so obviously the nicotine replacement, they come in several different products: in chewing gum, vape, patches, lozenges. Bupropion or Wellbutrin, its effect is it increases dopamine. Remember before when we talked about the brain and when it's in addiction mode, it is hunting for dopamine. So essentially, we are replacing that dopamine with bupropion. Varenicline or Chantix, how that works is it works kind of the same way Suboxone works. It is a partial agonist, which means it comes around and it partially stimulates that nicotine receptor, but it also completely blocks it. So it's stimulating the nicotine receptor, resulting in a squirt of dopamine, which the idea is it satisfies the brain and it won't hunt for another cigarette. Onward to treatments for cocaine addiction and other psychostimulant addictions. Although there are no FDA-approved medications for these group of addictions, there's been a lot of research at the NIH level. And there's actually some evidence-based support for the use of some of these things that we're going to talk about. Again, there's nothing FDA-approved. These strategies all increase the activity of dopamine. And if you think about what cocaine and other psychostimulants do is increase dopamine. So if, again, you're replacing the illicit sources of dopamine with licit sources of dopamine, it can be helpful. So some of these approaches include amantadine. Amantadine is a medication we use for Parkinsonian symptoms and actually the flu. It's known to increase dopamine, and its advantages, it's not a scheduled drug, so you can give refills of this medication. Another group of medications are these medications that are FDA approved for narcolepsy and sleep apnea. Provigil, Nuvigil, modafinil or armodafinil. Although it doesn't technically increase dopamine, it's thought to increase another chemical called histamine, which can be activating and promote wakefulness. It may mimic the effect or the feeling of these psychostimulants by increasing the activity of that chemical. Moving forward, we're going to talk about antabuse, and if you were paying attention earlier, antabuse is indicated for another dependency, namely alcohol use disorder. But one thing that antabuse is thought to do is to also increase dopamine. So there has been some research and some evidence for the use of antabuse in psychostimulant dependencies. Obviously, replacing the illicit with a straight up licit stimulant may be helpful if your patient has ADHD, and if it's clinically indicated, then you treat the ADHD, and the choices that are available, there are a variety of different stimulants, including Adderall and methylphenidate or Ritalin compounds that has been helpful for that. There's been some talk in the last decade of a vaccine for cocaine, and the theory is the vaccine will attach to a molecule of cocaine, and it becomes a larger molecule, so it can't go through the blood-brain barrier. That type of technology is the reason why certain antihistamines are not sedating, because the bigger the antihistamine molecule, you can't go to the brain, and it doesn't produce sedation. Compared to the old antihistamines like Benadryl, it goes right through the blood-brain barrier, affects the brain, and you get the sedation from that. So knowing that pathway, they've been kind of researching if there is a opportunity to use that technology in certain addictions. Again, it's been talked about for the last 10 years. So far, there's still just a lot of talk. And then there's a recent development of the use of buprenorphine naltrexone combo. There has been some nice studies, but still in the research phase. Now, one thing that we talked about is not putting your patient all in the same bucket, because everybody not only has different experiences, they may have different conditions. And along with that, they may all have different genetic makeups. So there's a term that you'll hear about in medicine called personalized medicine, which refers to the use of genetics and the knowledge that we have based on the interaction of drugs and your specific genetic makeup. There are companies out there that are specializing in what we call pharmacogenetics, that looks at how the body metabolizes drugs or predicts the response to certain medications. So here on this slide, I've just listed a few of them that I find very helpful in determining which way to go with some of my patients. The first one is called OPRM1, which stands for opiate receptor mu-1, and that can predict if somebody's going to have a good response to naltrexone for alcohol use disorder. Okay. The next one is GRIC1. That would predict the response of topiramate for an anti-craving approach for alcohol use disorder. The next genetic signal that I like to look at is GRIC1, which predicts the response of topiramate as an anti-craving effect for alcohol use disorder. Some people respond to topiramate, and it's sometimes recommended to consider topiramate if the other strategies don't work. And there may be a genetic reason why some people respond to topiramate as an anti-craving. Toparamate's used a lot in psychiatry. It's used, first of all, it's a medication for seizure disorder and also migraine headaches. But we use it off-label for a lot of things, including anxiety and weight loss. Some people feel like it's better as an anti-craving for beer or carbonated beverages versus the liquored spirits. COMT is another signal that I look at, and COMT describes how dopamine is metabolized. Now, if the COMT is a highly active signal, that means it's burning through the dopamine much quicker, which would result in dopamine levels lower than the average. So people with high activity COMT have a dopamine deficiency, which means that the brain is looking or hunting again for dopamine. So if I see this, a strategy for me would be, okay, what approach could I implement to replace that dopamine deficiency? The next signal is called MTHFR, which is short for methylene tetrahydrofolate reductase. And that's an enzyme that does only one thing. It breaks down folic acid to its usable form of L-methylfolate. And why that's important is because if you have a deficiency in L-methylfolate, you can't use that methyl in the L-methylfolate as a methyl donor to help things happen in DNA synthesis. So what happens, shall we start over again?
Yes.
Okay. The next signal I like to talk about is called MTHFR deficiency. Now, MTHFR stands for methylene tetrahydrofolate reductase. It's a very common deficiency actually in the general population. About 30% of the general population have this deficiency, and frankly, you can't notice anything. However, it is associated with certain conditions. Historically, it's been kind of looked at as a risk factor for miscarriages and poor outcome in pregnant women. And that's why we give pregnant women high doses of folic acid, because it is so common. So the reason why people have miscarriages over and over again may maybe the MTHFR deficiency may be involved in that. It's also involved in depression and anxiety. Anecdotally, about 80% of the people that see me, it feels like sometimes 100%, closer to 100%, in a walk-in psychiatric clinic like mine, has MTHFR deficiency. So before doing anything, before starting a psychotropic, before taking things away, one approach is trying to identify this deficiency, and if it's identified, I supplement with L-methylfolate, and that sometimes can cover some or most of the symptoms that they're complaining about. Now, people don't tell you, or psychiatrists won't tell you, that antidepressants don't work all the time. As a matter of fact, they don't work most of the time. They only work 30% of the time for people who have regular major depressive disorder. There may be a genetic signal for a genetic reason for that. And the next signal that we're going to talk about is SLC6A4. And this signal predicts response to your typical SSRI. This signal also predicts response to ondansetron for alcohol use disorder, and if somebody would respond to that as an anti-craving strategy. Ondansetron is a generic for Zofran. It's an anti-nausea medication that has some activity in the serotonin neighborhood. And then lastly, DRD2.
Let me pause you right there. And lastly, we're going to pick up right there. Just take a step backward, just a little bit. You kind of came a little closer, and left it, didn't shut the door. So we're picking all that crappy up, and are still rolling.
And lastly, we're going to talk about DRD2. DRD2 historically, if you look at the addiction medicine literature, always kind of showed up as being described as a genetic reason for addictive disorders. We know that there's not just one gene for addiction, but it always showed up as being something that was involved in something we called the reward deficiency syndrome. So you'll see and read about those terms. They still pop up, but it refers to, again, your brain looking for reward, hunting for that dopamine. And if you have a deficiency in the DRD2, you might be a little at risk for looking for that dopamine. Now, I promised you in the beginning that we were going to talk about new devices that's FDA cleared for certain addictions. And this next device I'm going to talk about, I have a real close relationship with, because I was part of a team that developed its use and discovered its use, and which eventually led to an FDA clearance for opiate use disorder. It's called the Bridge device. Up until then, there was nothing that was FDA cleared for the use of opiate withdrawal. So essentially, our team back in St. Louis essentially invented a space that was not described in the literature before. Something that was used as a electrical device to interfere with this electrical thunderstorm that was occurring in the brain during opiate withdrawal. So basically, we theorized that if we could get access to cranial nerves in the brain, specifically we thought that accessing 4 cranial nerves, cranial nerve 5, 7, 9, and 10, we could get access to the deep parts of the brain. We were more interested in the cranial nerve number 10, which was the vagus nerve. Some of you have heard about the vagus nerve. It's a very popular nerve, and it's the longest nerve in the body. It starts in the brain, controls some of the head, and then goes all the way down to the gut and to the organs. And so we thought that if we could gain access to the vagus nerve and stimulate it, we could flip over some of those symptoms that were present in opiate withdrawal. So we also thought that we could interfere with pain signal transmission. We thought that stimulating some of these neuro pathways could possibly release endorphins. And what we discovered almost serendipitously, that we gained access to a deep part of the brain called the amygdala, which was responsible for anxiety. And I'll show you on the second slide how we discovered it. But the idea is it's worn for 5 days during the worst part of opiate withdrawal. And once you're completely detoxified, we transition to medication-assisted therapies. Remember, we talked about the importance of detoxifying somebody completely before introducing an antagonist therapy, because if you throw in the opiate before they're completely detox, you can throw them into withdrawal. So it was designed to be worn for 5 days to treat the symptoms of opiate withdrawal, and we're doing this along with comfort medication. So it's not only the device, there's other symptoms that the device doesn't treat, but it can cover most of the symptoms. So it's not only used by itself, it's used with other comfort medications with the goal to transition to antagonist therapy. It's called the bridge. So this was the result of our study, our retrospective analysis of all our data that we submitted to the FDA. Once we submitted our results to the FDA, they quickly cleared it for use and being marketed in the United States. So this was the average COW score when patients came in, which was 20, which is pretty bad withdrawal, moderate withdrawal. And after 20 minutes, you saw that it went down on average, to about 7. And then after day 5, it was down to 1 or 2. So you see how this could be helpful in controlling those symptoms and transitioning comfortably onto medication-assisted therapies. So all patients had a reduction of at least 31% after 30 minutes. 86% reduction of COWS, the clinical opiate withdrawal scale, after 60 minutes. A 97% reduction of the COWS score after 5 days. And 88% of our patients transitioned onto antagonist therapy. So we were talking about earlier about how we figured out it had activity in the amygdala. I had a colleague from the University of Wisconsin who put these devices on mice, and they measured the signal or the activity in the amygdala. And we found out that these devices reduce the firing of the amygdala by 52%. And that made sense to me because the amygdala was like the center of anxiety and fear. And we saw a lot of the anxiety and fear kind of go away or improve significantly after putting on the devices. We also found out with these with these rats that spinal cord firing was reduced by 66%. Now, if you think about what controls the pain pathways are these signals that go up and down the back and the spine, right? So during opiate withdrawal, it's like a thunderstorm back there. There's a lot of activity of these pain signals. Putting on the bridge reduced the spinal cord firing by 66%, which was extremely significant. So this was like a timeline. September 2016, there was a case study submission to my society, the American Society of Addiction Medicine, but it was rejected, partly because we didn't have enough cases and partly because I feel like the results were so unbelievable. They didn't want to expose this signal that we had kind of discovered. So we gathered more cases. We put together a report, resubmitted it to the Journal of Drug and Alcohol Abuse, and it was finally accepted and published in March of 2017. Now, several months later, based on that paper, the FDA cleared the bridge device for opiate withdrawal. So it was approved in 2017. Unfortunately, it's 2024. And despite our efforts and despite my team going in front of the CMS boards and Medicare, it's still not covered widely, actually not covered at all by Medicare, Medicaid, or any private insurance companies. And it's kind of used as a self-pay option, unfortunately. So other new technologies that we're using and may provide some other options in addictive disorders include transcranial magnetic stimulation, or TMS. Now, this has enjoyed some popularity the last couple of years because it has been used specifically for treatment-resistant depression. Now, these machines are highly effective. The issue with this is you got to have some time commitment. You got to come into the clinic every day for about 20 minutes and receive the therapy. And you got to do the therapy Monday to Friday for about 35, 36 times. And we see a 60 to 70% remission rate in depressive symptoms. So it's a very good option for treatment-resistant depression. It also got a indication for smoking cessation. So it is used for that. However, it's quite, even though the FDA approved it for that space, it's quite expensive for that condition. And I think insurance companies are more willing to pay for the medications and nicotine replacement. But what's more important is it proved that these cranial stimulators could be helpful in interfering with that neurocircuitry that's involved in addictive disorders. Another indication that TMS is used for is OCD. TMS is a growing technology. I think if has to do anything with the brain, they're studying it. So stay tuned with more indications for transcranial magnetic stimulation. Lastly, I think we have to talk about ketamine and psychedelics. Ketamine is a new player in the field of treatment-resistant depression. It's used now as a nasal spray called Spravato. However, it's been used in different forms such as IV and IM, and they've been using it for a little bit. It's a dissociative anesthetic used in veterinary settings and ERs. However, it's been used now for treatment-resistant depression. Psychedelics is kind of enjoying a kind of resurgence. Now we're talking about mushrooms and LSD and MDMA as possible options for depression, anxiety disorder, and PTSD. However, there's nothing official, but I know that there's a lot of research surrounding psychedelics these days. So one thing that we learned in the COVID years is that we were forced to reach out to our patients via telemedicine. We couldn't do the traditional face-to-face, and we were all worried that what would happen to our clients that were in recovery, because historically substance use disorder treatment was a very social event. You went to groups, you did therapy. However, we proved that during COVID that telemedicine and other digital therapeutics actually very, very effective. What we saw was it was just as good as traditional face-to-face. There was shorter wait times, if you can imagine. Not a lot of chit-chat in the office with lots of people, and the doctor got to see patients more efficiently. There was increased privacy because they were at home. There's reduced stigma. If you can imagine, somebody who's not doing well and kind of drinking or using, they're not going to show up in the office because of shame and guilt. However, if that's happening at home, they can jump on and still engage in their treatment. The care was more continuous. The home environment was a lot more comfortable. And we started using digital tools, which means, we had all these scales that we could implement, measuring their anxiety and depression and their withdrawal symptoms. So at the end, we found that telemedicine was not only effective, that in some settings it was superior to some other face-to-face settings because there was more engagement. Okay. So lastly, what should we do as physicians and providers when we treat our patients with substance use disorders? So first thing, you have to be friendly and non-threatening. If you can imagine, everybody in their family and friends are judging them. There's a lot of, again, shame and guilt. For you not reenacting that gives them a more trusting experience. It's a safe environment. They can come to you. Convey an attitude of concern and curiosity. Avoid being authoritarian or judgmental. If you can imagine, a lot of people who are, you're a bad person, you're just a loser, they're going to run away. And if that happens, they're going to run away from you. Reassure that all information is confidential. Offer medical interventions as a component to treatment options. Not a lot of people realize that there are injections for cravings or devices for withdrawal or devices for their depression. Most people don't know about those things. And lastly, manage your countertransference. And that countertransference is a term that we use in psychology and psychiatry, which refers to our own feelings towards the person. For example, if you feel like this person is playing games or not trying as hard, you have your own feelings and you want to reach across the desk and kind of strangle them, go, what's going on with you? Sometimes that gets in the way of treatment. So we always have to be mindful and manage our countertransference, because if we say the wrong words, again, they're not going to come back and they're not going to engage, and then you're going to lose them. So finally, refer to the professionals. There are a group of us that are trained specifically for addiction medicine. There are a growing amount of training programs in the country that are training doctors to be certified in addiction medicine, and keep an open mind. And again, there is hope, and addiction can be treated successfully. So I hope you enjoyed this conversation, and I'll see you at the next lecture.